joining us. So I'll let Satish, who's president of the, American Autonomic Society, introduce you formally.
Thank you. Before that, the other key thing you can learn, Arthur, is -40 is where it doesn't matter if it's Fahrenheit or Celsius, it's the same. On that note, we are blessed today to have Artur Fedorowski speak to us from balmy Malmo, where it's only -5 currently, for our cardiac grand rounds. Arthur is a cardiologist who also specializes in autonomic disorders and runs a very large referral clinic in Malmo, Sweden. And with that, he's actually set up a phenomenal clinical research infrastructure where he's been able to get both physiologic data as well as samples in a large number of patients with different disorders of orthostatic intolerance, ranging from syncopal disorders to orthostatic hypotension to POTS. And he's really started publishing some very nice papers to try and offer insights into possible mechanisms in pathophysiology at a biochemical level. That's not what he's going to talk about today. The other part of what he's done with some of the epidemiologic data is he really has become an expert and maybe the world expert in why orthostatic hypotension is bad for you. Right. So I usually focus on acutely, we want to prevent falls and things like that. And that's obviously a good thing to try to do. But Arthur has a lot of insights into how the presence of orthostatic hypotension seems to relate to all sorts of other bad things, both cardiovascular and non-cardiovascular. And I think he's going to share some of those insights today. He's an associate professor. I'm sure that's not going to be for long. I expect him to be a full professor soon at Lund University. And I'm excited to have Arthur come and share some of his insights with us today. Arthur?
Well, thank you, Satish, for this great introduction. It seems that someone is reading our papers. So it's great. So because time is short, so I will start right away with our presentation. This is about a bad company. Orthostatic hypotension is a bad company for your brain, the heart, and the bones. And why, I will try to explain it to you in this maybe a little bit too long presentation. You can judge it afterwards. So we should talk about the historical background of orthostatic hypotension. It's good to know how this term came about and the epidemiology of orthostatic hypotension, the pathophysiology, the association of orthostatic hypotension with organ diseases, and then what are the knowledge gaps and the present, and then we conclude this brief presentation. So what about the historical background? We use this term quite often, but we ask ourselves sometimes, how did it all come about? Actually, in 1925, the American Heart Journal published a series of cases under the name Postural Hypotension, a report of 3 cases by Bradbury and Eggleston. They used the term postural hypotension. It happened to be a pure autonomic failure according to our contemporary terminology. But actually, they didn't use the term orthostatic hypotension. It was used for the first time by Lobry and Dumet in La Presse Médicale, 1932, as l'hypotension orthostatique. And accidentally, a few years later, a few doctors from Iowa City, Brian Olshansky capital, Horace Marshall Cones and William Lloyd Randall published orthostatic hypotension treated with benzathrin paper, and which is even more interesting, what they wrote in this paper was the pathogenesis of orthostatic hypotension is still largely a matter of speculation, and no uniformly successful treatment has been discovered. Please keep that in mind. This is the American Heart Journal, 1941, when one speaks about no good treatment for orthostatic hypotension. It's 80 years ago, actually. So, having known what orthostatic hypotension is and how this term came about, let's move to the definition of orthostatic hypotension. It's good to know how it is defined today. In this autonomic consensus from 2011, there is a magic number, 20 millimeter mercury of systolic blood pressure reduction on standing as the standard for orthostatic hypotension within 3 minutes of standing. Please keep that in mind as well. Two subtypes are mentioned, delayed orthostatic hypotension and so-called initial orthostatic hypotension. A few years later, the American cardiological consensus from 2017 used the same numbers again, 20 millimeter mercury blood pressure fall in systolic blood pressure on standing, or diastolic reduction of 10 millimeter mercury. Interestingly, the same subtypes named here, initial orthostatic hypotension, actually no cutoff limits are given here, but we know that this is 40 millimeter mercury on standing. I mean, reduction of 40 millimeter mercury in systolic blood pressure on standing. Then classic orthostatic hypotension is mentioned here, delayed and so-called neurogenic orthostatic hypotension. So that's a little bit confusion. Classic orthostatic hypotension is what is called orthostatic hypotension in the autonomic paper. So after these two papers, the third one from Europe, the Syncope consensus from 2018, the European consensus, cardiological consensus on syncope, where you can find this definition, again, 20, 10 millimeter mercury, and then standing blood pressure below 90 millimeter mercury of systolic blood pressure as the additional criterion. So it makes the confusion probably even worse. And then in the practical guidelines that followed the main body of document, you may again find initial orthostatic hypotension, classical orthostatic hypotension, and delayed orthostatic hypotension. If you look into the text, with the same cutoff limits as in the two previous papers. So the first question you may ask yourself is whether we need to look at diastolic blood pressure at all. Actually, in this paper, that was published a few years ago, we look at syncope patients, and we could observe that 95% of patients diagnosed with orthostatic hypotension could be diagnosed using systolic criterion only. There were 3 patients diagnosed with orthostatic hypotension where the systolic blood pressure didn't meet the criterion. However, if you look at the absolute values, they met the European criteria from 2018. So the question is whether we need at all to look at diastolic blood pressure to find or to diagnose orthostatic hypotension. Probably it's going to be reconciled in some way in future guidelines. In this nice paper published just recently, if you look at the curves on your right-hand side, you will see how it looks like when the blood pressure fluctuates or changes on standing using continuous blood pressure monitoring. It is very important to use this technology to see what happens with the blood pressure or to determine which variant of orthostatic hypotension we are talking about, as these changes are very fast. And you can see only classical orthostatic hypotension within the first 3 minutes when you use the traditional methodology, intermittent blood pressure readings. So continuous blood pressure monitoring is mandatory to see what happens within the first minute. And as you can see here, the initial orthostatic hypotension occurs within 15, 20, 25 seconds after standing, whereas, as you can see, the classical orthostatic hypotension means persistent blood pressure reduction on standing. Of course, if you want to see delayed orthostatic hypotension, you have to wait a little bit more than 3 minutes. So I hope that you can now, you got an idea what orthostatic hypotension is and how it is defined. But this is all about actually one major hemodynamic parameter, blood pressure, and how it changes on standing. So now let's look how many are affected by this syndrome or this condition. And if you just keep in mind the young, the old, and the sick, then you can make it very well in identifying major groups that are affected by orthostatic hypotension. On your left-hand side, you see that the proportion of general population affected by orthostatic hypotension of classical type, defined by two measurements at baseline in the population-based Malmo preventive project, is increasing across the age groups from 3% below 30 years until 9% in the age stratum above 48 years. And we know from other studies that orthostatic hypotension prevalence is increased in the age of 70 years in hypertension, diabetes, renal and heart failure, in neurodegenerative diseases, in cancer, and in autoimmune diseases. Younger patients used to be more affected by this initial transient variant just after standing. If you look at the epidemiology of orthostatic hypotension in the segment of patients that suffered syncope, again, you will see almost the same pattern here. In the younger age, you don't see so many orthostatic hypotension patients, but just around the age of 70, the numbers start increasing in a very pronounced way. And in the study by Ungar, among syncope patients above 75 years old, you will find 30%, 1/3 of the population affected by orthostatic hypotension, actually, as the main etiology of syncope. So there's quite a few people with orthostatic hypotension out there, especially among younger patients with initial variant and among older patients above 70 years old with both classical and delayed variant. So now we would like to talk about the pathophysiology of orthostatic hypotension. And I plan to cover 5 major issues here: baroreflex failure, neurogenic versus cardiogenic variant, hypotension, hypertension syndrome, and why don't we feel we have orthostatic hypotension, and the giraffe syndrome. I know that it sounds a bit intriguing. Let's wait a little bit. You will see what I mean. So blood volume shift while standing makes a rapid move of around 1/2 or 1.5 and up to 1.5 liter blood moving from thorax down to the lower part of the body. So, of course, this is a challenge for the body to keep the blood pressure on the right level above the level of heart, of course, on standing. This is what's happening on standing. So the body tries to compensate it through 2 compensatory mechanisms, higher heart rate and increased vasoconstriction. And as you can see in this diagram, which actually comes from our PENI publication, There are two main mechanisms of orthostatic hypotension, either pump dysfunction or pipeline dysfunction, meaning cardiac dysautonomia or vascular dysautonomia. And the cardiac part of the orthostatic hypotension used to be forgotten sometimes, because we believe that everything which is important for orthostatic hypotension is happening in the vessels. Actually, you may have pump dysfunction as well. You may have chronotropic insufficiency. You may have left ventricular dysfunction, diastolic dysfunction, pulmonary hypertension, and valvular pathology, in general, reduced cardiac filling. And the pipeline dysfunction means that there is impaired vasoconstriction, which is very typical for neurogenic orthostatic hypotension. Then you may have venous pooling and impaired venous return, which can affect cardiac filling and cardiac output as well. So this is a sort of cardiogenic version of orthostatic hypotension, if you look at the pathophysiological side of the problem. Now, in this summary, you may see the main difference between what we call neurogenic orthostatic hypotension and the new term that we are now trying to promote a little bit, cardiogenic orthostatic hypotension. So low systemic vascular resistance dominates in the neurogenic type, whereas low cardiac output dominates in the cardiogenic. Of course, the story is not that easy, especially in the elderly. You may have patients with hypertension, with diabetes, with renal failure on your right-hand side, and then this clinical picture is much more complex, and usually you have to do with a mixed form of orthostatic hypotension, both neurogenic and cardiogenic type. And in the worst case, this is not only about hypotension. You see these very pronounced hypotensive episodes during daytime, but then you have severe blood pressure swings this afternoon, and then during the night, you see the hypertension. So these compensatory swings produce, in the end, nighttime hypertension, which is very detrimental for different organs, internal organs such as brain, the heart, and the kidneys, and others as well. We'll talk about it a little bit later. So orthostatic hypotension is not only about hypotension, we should keep that in mind. Now we're gonna move to the fourth aspect that we'd like to discuss here in the pathophysiology segment. Why don't we feel orthostatic hypotension? As you can see in this diagram, this lady with orthostatic hypotension doesn't feel so much during tilt testing. At one point, when the cerebral oximetry, which is progressively going down, at one point when this cerebral oximetry reaches the level of 60%, she starts feeling dizzy. And then from that point on, the feeling gets more and more intensive, so that we have to terminate the test in the end. So what about the period between head up, tilt, and the blue arrow? Blood pressure goes down, the patient doesn't feel anything. How is that? The answer is cerebral autoregulation. So the cerebral vessels try to compensate blood pressure swings to protect brain. Brain is very valuable for the body. Actually, brain is more valuable for the body than the heart. I have to admit it, frankly. And the system is pretty well working within the range systolic blood pressure 80 to 200 millimeter mercury. And as you can see here, what happens when the blood pressure goes down below this magic limit is that the cerebral vessels dilate maximally, but they cannot compensate anymore. And then the cerebral saturation goes down and you start feeling dizzy. Actually, what happens first is that you feel a sort of blackout because your eyes need a little bit higher pressure to get sufficiently amount of blood to work. So the first thing that you feel when blood pressure goes down is that your sight is getting worse. On the other end of this continuum, what's happening when blood pressure goes up is that the maximal constriction is not good enough, and then the vessels actually may dilate, producing headache and other symptoms typical for very high blood pressure. But in between these two limits, you see the plateau, and you will not be able to see any differences in blood pressure actually in your brain. Now this intriguing picture and the giraffe dilemma. Giraffe is actually the tallest animal walking on the earth, between 5.5 meters tall. So it's a lot of body. It's a very tall body. So how is that giraffe do not have orthostatic hypotension? It is very intriguing, and we have actually studied this issue with great interest. If you look at the head of giraffe 4 meters up, so the blood pressure at the level of giraffe's brain is 75 millimeter mercury. And at the level of heart, 250 millimeter mercury. And at the level of hooves, it's 400 millimeter mercury. These are very big forces, very high pressure. And how is that giraffe can live at all? Actually, they sleep on standing. So it's very amazing. They don't have to lie down to sleep. They can actually be sleeping on standing. So the answer is that there is a few adaptive processes here that take place, and the most spectacular adaptive process is hypertrophy. So there's a huge heart weighing about 11-12 kilograms, and there are hypertrophic vessels. All of this makes giraffe maintain their very high blood pressure. They don't get myocardial infarction due to myocardial hypertrophy. They don't get atherosclerosis. Everything was perfect, with some help of valves as well. But if our body is exposed to the same forces, what may happen in the body with orthostatic hypotension is that the body may develop hypertrophy of the vessels and hypertrophy of the heart. And this is exactly what happens when you have orthostatic hypotension. So this giraffe's phenomenon, giraffe's dilemma, may explain one of the association between orthostatic hypotension and cardiovascular disease. So this is definitely a bad company for our internal organs, and especially for cardiovascular system. What may happen is that not only you may feel dizzy, you may faint during hypotensive episodes, but you may develop stroke, cardiac complication, and renal failure due to hypertension during nighttime when you're lying down. And to understand the cardiovascular consequences of orthostatic hypotension, we have to look in a more systematic way at the different parts of the process, from genes to phenotype, to the final phenotype. So we have studied orthostatic hypotension using different approaches. One of the approaches is proteomics, that was mentioned by Satish in his introduction. And in one of our studies, we look at specific technology, Olink technology, which is high throughput proteomics methodology, identifying at the same time around 90 different biomarkers, protein biomarkers. What we found was that patients with orthostatic hypotension have higher levels of matrix metalloproteinase 7, which is engaged in the rebuilding of the extracellular matrix, just like in hypertrophic processes in atherosclerosis as well. This is a biomarker of atherosclerosis with hypertrophy. So we might say, bingo, now we found it. Then this marker is also very interesting. It was upregulated in orthostatic hypotension. And this is a biomarker, which is called kidney injury molecule. And of course, as the name suggests, this is a marker of kidney injury. So we have a marker of hypertrophy and marker of atherosclerosis and kidney injury in orthostatic patients. So this might explain the connection between orthostatic hypotension, cardiovascular autonomic dysfunction, and cardiovascular complications. And of course, this is molecular level. But what about the phenotype? What about the epidemiological level that was mentioned by Satish as well? In this very nice meta-analysis, Richie and colleagues, one of these colleagues who was actually myself, looked at different studies where the baseline prevalent orthostatic hypotension was associated with different cardiovascular endpoints and all-cause mortality. And all the findings were pretty consistent. All-cause mortality, especially in the younger segment of population, heart failure, coronary heart disease, and stroke, all of these endpoints, cardiovascular endpoints, were consistently predicted by the prevalent orthostatic hypotension at the baseline. So this picture is quite consistent. All of the typical endpoints are predicted, or we can, of course, infer promoted by the presence of cardiovascular autonomic dysfunction. And not just to brag about our achievement, but just to give you the idea how we studied this issue, we have summarized our different studies performed between 2009 2018 on orthostatic hypotension and different cardiovascular complications. And the picture is very, very consistent. You may say something like that. Wherever you touches orthostatic hypertension and whatever endpoint cardiovascular complication you touches, there is connection. There's some connections are stronger, some connections are weaker. But if you look at arteriosclerosis, left ventricular hypertrophy, myocardial ischemia, coronary thrombosis, myocardial infarction, remodeling, arrhythmias, and especially atrial fibrillation or heart failure, you see the connection between orthostatic hypotension and all of these cardiovascular complications. This is very convincing. And actually, orthostatic hypotension should be put in the same line as risk factors in the middle of this diagram. You have dyslipidemia, hypertension, diabetes, smoking, obesity. But where is cardiovascular autonomic dysfunction? It is not acknowledged yet. And I would like to convince you that this is very important, just in a few seconds. So, are we the only ones in the world that notice that? Not really. There's a huge body of knowledge, huge body of proof connecting orthostatic hypotension with mortality, with cardiovascular death, heart failure, coronary disease, stroke, atrial fibrillation, and vascular changes. Different groups, different populations, and the results are pretty consistent if you look across these different studies coming from different continents. There are studies from Europe, from America, from Asia as well.
What's that?
So now,
Yeah.
if we can summarize it in a very nice way, if you put orthostatic hypotension in the center, or orthostatic hypotension as a marker of cardiovascular autonomic dysfunction, you see that in this cardiovascular continuum, orthostatic hypotension touches all the important point of cardiovascular integrity, leading to different processes, just like atherosclerosis and inflammation, hypertrophy, heart failure in the end, arrhythmias, atrial fibrillation, and so on. So this picture is very consistent. And not even cardiovascular disease. We are talking about other organs as well. In the nervous system area, orthostatic hypotension has been associated with dementia, with syncope, of course, skull trauma, with white matter lesions as well. In the respiratory system, orthostatic hypotension has been associated with the development of lung disease, chronic obstructive pulmonary disease. As far as kidneys are concerned, with kidney failure. As far as circulation is concerned, with orthostatic hypercoagulability, especially von Willebrand factor increase. And as far as bones are concerned, of course, fragility fractures are very closely associated with the prevalent orthostatic hypotension. So this is quite a detrimental condition, and we're not talking about falling and breaking your bones, breaking your legs. We're talking about your internal organs that may be affected by the prevalent cardiovascular autonomic dysfunction. Having said all of this, there are some gaps in knowledge, and we have to admit it. The pathophysiology of non-neurogenic orthostatic hypotension is not really well understood. And even if I showed you a diagram, an idea how we should classify orthostatic hypotension, we should keep in mind that this is not a final knowledge. We don't know whether the problem is on the arterial side, on the venous side, which types of veins are mainly concerned here, whether there is a impact on the circulating blood volume through some neuroendocrine interactions. This has to be explained in future studies. Next point, which is very important, is how to treat orthostatic hypotension. As you may remember, probably 80%, maybe 85%, maybe 90% of people affected by orthostatic hypotension, they do not sense it. They don't know they have it until they get very dizzy or until they faint. But if we detect orthostatic hypotension in your patient, should it be treated to prevent cardiovascular disease and organ damage? Actually, we don't know that yet. And if we decide to treat it, the question is what to treat, how to treat, and what are the limits here? Should we optimize the treatment for risk reduction, or should we optimize the treatment to reduce the symptoms? So again, there are huge gaps in knowledge, and probably the most important aspect here, the treatment is not so well working in orthostatic hypotension. Now, to convince you that this is an issue that actually require our attendance in the future, is if you look at the diabetes and orthostatic hypertension, these two conditions are pretty prevalent at the same level. They both increase with age, they are mostly asymptomatic, they both increase mortality and cardiovascular morbidity. Actually, diabetes does not directly impact your quality of life. But if you ask any doctor in the world, they would answer, this is a very big health problem, and multiple treatment options are here available. Just look at your pharma book. Orthostatic hypotension may lead to serious injuries, impacts your quality of life in a serious way. But people, if you ask them, doctors, you ask them, oh, this is just about young women and older frail patients, and no good treatment options at all. And I took the liberty to look at the PubMed, and I used some search words: hypertension mortality, diabetes mortality, and orthostatic hypotension mortality. This is the results. More than 50,000 records for different publications, hypertension and diabetes and mortality. If you look at orthostatic hypotension and mortality, you will find only 481 records. So this disparity is huge. This is enormous. To conclude, orthostatic hypotension is a marker, is a sign of cardiovascular autonomic failure, and is of course a heterogeneous condition. It's often asymptomatic, and we know that its prevalence increases with age and other comorbidities. And, first of all, diabetes, hypertension, diseases of the nervous system, renal failure, cancer, and autoimmune disease as well. And we know for sure now that orthostatic hypotension is predictive of mortality and of incident cardiovascular disease. It predicts syncope and fractures and traumatic falls. This is obvious. Dementia as well. This is more or less obvious. And even lung disease and many other conditions, what we not yet looked at. Finally, and now let's move to one of the previous slides in the very beginning, the second slide actually, about the history of orthostatic hypotension. Orthostatic hypotension is understudied, no doubt about it. But do you remember the statement from the paper from 1941? No uniformly successful treatment has been discovered. And we may just quote it again now. So I'd like to thank you for your attention, and I hope you enjoyed this presentation. Thank you.
Thanks, Arthur. That was really good. Any questions? I think I see some questions here coming in the. So someone is asking that orthostatic hypotension is very common in hemodialysis patients with large volume fluid removal over 4 hours and is rebound hypertension and dilated cardiomyopathy. Diabetes is also very common too. Is there evidence that MMP and TIM are elevated in hemodialysis patients?
Oh, I have no evidence on it, of course, because I have not studied this sort of patients. But you can easily test it by yourself using one of the assays that are available on the market. Mm-hmm. It would be very interesting, actually, to see if there is difference between orthostatic hypotension dialysis patients and non-orthostatic patients.
Okay, so let me ask you something. So orthostatic hypertension, it's really a marker or it's just a bystander? Is because, you know, everything you show on that circle kind of seems to all point to inflammation, including MMP7, which is more of an inflammatory marker. So how do you tease that out? And if so, how do you treat it?
Oh, I would say that orthostatic hypotension is a condition, a sign, a clinical sign, and is also a marker of a disease or dysfunction in the autonomic system, in the cardiovascular autonomic system in particular. So you cannot call orthostatic hypotension a disease per se because of this, of a very heterogeneous character of the etiology. And if you ask me, when do you treat orthostatic hypotension? I can ask the same question to you. And obviously, we treat orthostatic hypotension patients when they are symptomatic. So we treat probably 10-15% of all patients that do have orthostatic hypotension. So we treat symptomatic orthostatic hypotension. This is my answer.
So, but my question is, this is something that I compared to, asymptomatic atrial fibrillation. So should we be treating actually asymptomatic orthostatic hypotension because of all these other risks that you've already shown, increase in mortality, increase in bone fragility, as a matter of fact, dementia. So because one of the things that, you did notice is that, the blood pressure can be very low and people don't feel any symptoms. So this has to do with some, change in the, set point in adaptability of cerebral brain perfusion. But, these people are having cognitive decline. So what if we actually intervened earlier? Would we be able to prevent all these other issues with bone fragility, cardiovascular mortality, cognitive decline?
This is a very good question. First of all, I think that probably patients with orthostatic hypotension should be treated in a different way against hypertension as usual, typical hypertension patients. This group is not very well characterized in hypertension interventional studies. I think that SPRINT study was one of the first ones that looked at this aspect. There was some concept with the design of the study, of course, but I think that in the future, we should identify this group of patients in interventional study. Probably they should not be treated from the very beginning with vasoactive drugs to increase blood pressure, but probably they should be treated in slightly different ways as far as hypertension is concerned. And probably we should promote nighttime treatment of hypertension. So we should focus upon nighttime hypertension as the first target for clinical intervention. So nighttime hypertension as the, let's say, epidemiological treatment, and daytime hypotension in symptomatic patients as symptomatic treatment.
Okay. So a little bit about treatment, because, we kind of classify these as, neurogenic and all these other classifications that you gave us. But in the end, the treatment pretty much the same for each one of them. So what would you say, one of the challenges we all have is with, with supine hypertension in the patient that also has orthostatic hypotension. So practically, how do you treat these patients? So let's say a 75-year-old guy that is having significant orthostatic hypotension, is very symptomatic. He's on an ACE inhibitor, an ARB. His blood pressure sometimes is over 150, over 100, but he does have a diagnosis of orthostatic hypotension, and the tilt test is delayed. So how do you treat these people?
I would start with 24-hour blood pressure monitoring, ambulatory recording to see the profile. And then I will attack the profile. I will attack the sweet spots in the 24-hour blood pressure profile. So if there is a huge increase in blood pressure in the early nighttime hours, I would treat this patient at 8, 9, 10 o'clock with short-acting antihypertensive drugs, ARB or calcium channel blockers, trying to select more short-acting drugs, of course. And if you detect postprandial hypotension, then you might want to add some antihypertensive drug during the day. So you try to reconstitute the normal blood pressure profile with different drugs. This is how I work. Sometimes it works, but there are patients that are very symptomatic, and you may imagine yourself an old person, an old man who gets up in the night just to go to urinate at night. He doesn't think about his orthostatic hypotension. You just press the hypertension down, but then he develops orthostatic hypotension and breaks his leg. So there are some dilemmas that are difficult to treat, of course.
Yeah, a lot of these people are on some of these, benign prostatic hypertrophy drugs that also produce orthostatic hypotension. But I think that the clue is that, yeah, I always do a 24-hour blood pressure monitor before I do anything else. And then I kind of titrate around their blood pressure medications and what I've seen in that 24-hour blood pressure monitor to decide, if I'm going to give them a little bit of Florinef or Midodrine or whatever. I tend not to give any of these vasoconstrictor drugs after, let's say, 5 p.m., which when people are basically either sitting or going to go to bed, just because this is going to promote some more supine hypertension. So that's one of the things that I kind of tend to do usually, and play around that. So there's a question about what's the role of sleep apnea as a cause of orthostatic hypotension?
I don't know. I haven't seen any good studies on it. If you have any good study, you can send it to me. I would read it with great interest, of course.
So I think the question was about the cause of it, and I'm not sure there are great studies on it. But there's actually some emerging data on the treatment of supine hypertension. It turns out CPAP does lots of useful things, but one of the things that mechanically decreases venous return by increasing pressure in the chest, and it's actually does lower the supine pressure. So if you want to avoid, you want to treat the nighttime pressure and you want to avoid giving drugs that vasodilate and may cause the patient to faint while getting up to pee, CPAP is actually a reasonable alternative if they're already have an indication like sleep apnea.
Oh, this is very interesting, actually.
Yeah. So how about any, there's been a lot of interventions for hypertension, like, renal denervation and stuff like that. Anything like that can we do for orthostatic hypotension?
Oh, you mean stimulation? Or
Exactly.
you have denervation, so we like to stimulate. I think this is on an experimental level, and I don't think that has been ever tested in humans yet. So, but the idea looks very promising, or you can use a sort of injectors with neurohormones that are acting as the second line of defense against hypotension. If the autonomic nervous system doesn't work properly, so you will have some of neurohormones acting as the reserve system, and you have vasopressin, adrenaline.
Yeah, that's where I was going. Like,
So maybe a sort of injector, maybe a sort of long-acting drugs.
Yeah, something like, if your Apple Watch, looks at your, peripheral vascular resistance and, and your blood pressure, and it detects that, and the same, Apple Watch gives you a little dose of Midodrine or Mestinon or something, or,
Yeah, of course. But one point I was thinking when you asked this question, so is there anything in the body that you can destroy in the autonomic nervous system that would increase the blood pressure? I don't know.
So just looking at it another way, there's an opportunity to put in a plug for some work that was recently published by colleagues here at the Libin Institute. So Dr. Aaron Phillips, who's a brilliant young, I don't even know what to call him. He does a bit of everything, but just a cardiovascular scientist, has a strong interest in spinal cord injury related orthostatic hypotension, right? So orthostatic hypotension probably a little different than the patients that Artur was talking about. And he has recently published a paper in Nature, not Nature something, but like Nature, like real Nature, where they've shown both in animal models and a proof of concept in a few humans that if you use spinal cord stimulators that have traditionally been used to help with motor function, but targeting them at specific areas, and part of what he's done is develop matrices to try and figure out where these areas are, that you can actually improve acutely orthostatic blood pressures, literally by turning on stimulation and then making them worse again by turning off stimulation. So this is very preliminary. It's not really ready for prime time, but it's an exciting proof of concept, and I think we'll be hearing more about this. And if you guys are interested in a slightly more basic talk at Cardiac Science Grand Rounds, I'm sure Aaron would love to come and spread the gospel about spinal cord injury, cardiovascular impairment, and how to fix it.
Yeah, that's where I wanted to go to. Is like, there's some preliminary data
So
that, spinal cord stimulation can actually do something like that. Yeah.
Yeah, I know what you mean. So instead of destroying the nerves, you can stimulate the nerves. And then it might be a solution, actually. It might be a solution. Stimulators might be a solution. I agree.
Okay, any questions, comments, Satish?
No, just, I'd like to thank Artur for a great talk. Happy to sort of do, talks on acute management, which is what we're, probably dealing with more on a day-to-day basis. But every once in a while, it's nice to sort of step back and get a broader perspective that Artur has shared with us today. So thank you, Artur.
Well, thank you for your comment.
Yeah, thanks, Artur. So enjoy the weather in Malmo.
Thank you, everybody. Thank you for inviting me.
You take care. Hope to see you sometime soon.
You too.
Bye now.
Bye.
Bye, Artur.